All right. All right, everybody. Whitney Lowe.
All right. Thank you, Tim. All right, so can everybody hear me okay? In the back, all right, good there? All right, very good. So this morning, well, the theme, the overall theme of what we're going to try to get at this weekend has a lot to do with, as Tim mentioned, with pain management. Pain science is sort of a big buzzword that's out in all the healthcare fields right now. Some of you may have been exposed to some of these concepts. Some of this stuff may be relatively new or unfamiliar to you. And so what I'd like to do this morning is sort of set the groundwork for, here are some of the key and core concepts related to what we're learning, what we're exploring, what we're looking into with pain science processes, and how this is relevant for us as massage therapists. Because what we find is that a lot of this stuff is different from profession to profession in terms of how it may really impact us. So I'm going to highlight and sort of focus on a couple of key points and key aspects of this process, and then we'll take that another couple steps with the panel that comes up here and with Nora's presentation following this as well. So some of this is going to get into some kind of heady neuroscience kind of stuff. Ask questions, because it's really better if you got something that's stumping you or whatever, don't hesitate to ask those questions, and I'll be sure to make up some bogus answer to whatever you ask, okay? No, seriously, ask questions, and certainly if I don't know something, I will be able to direct you to some places that will help you to get a good answer. So let's start off with this term. First of all, what pain science is. It's kind of a strange term because we don't talk about, like blood science or, muscle science or whatever. Why does pain have its own science? And there's a little bit of debate in the fields about whether or not this term is really appropriate. But in general, when we talk about pain science, we're basically talking about science applied to concepts of how pain is experienced in the body. Well, we're most interested in humans, but we're looking at how pain is experienced in the body and then how this plays into our attempts to treat and deal with pain problems. So that's our key focus. We'll start off with the definition of pain from the International Association for the Study of Pain, saying that it is an unpleasant sensory or emotional experience. And that's pretty common for what we all think of pain. This is the important part of this definition right here. When they talk about it's associated with actual or potential tissue damage. Actual or potential tissue damage. And this is an important thing to remember, because what we now are learning, and we'll explore this again in a few more minutes, is that pain can happen when there really isn't much tissue damage in many situations. And that has been something that we've tried to explore, like in trying to figure out why some people hurt sometimes when there doesn't seem to be a reason that they will be hurting. But their pain is absolutely real. And so this is something that's very important, is that it doesn't have to be because there is something explicitly physiologically wrong for there to be significant pain problems. So that's what we're going to be exploring and trying to get a good sense of how this plays into what we're doing with our field. So one of the places to start with, this is a metaphor about pain and how it works in our body. This is a really good metaphor to think about. Pain is an alarm system. It's telling our body, potentially, there's something wrong, there's something that you need to think about, there's something that you need to pay attention to. Have you ever been in a building when the fire alarm went off and there wasn't a fire? Okay. You ever been in your body when the alarm went off and there really wasn't a fire? Okay, same kind of thing can happen. The alarm system can get out of calibration and go off when it shouldn't sometimes. And that's what often happens when pain complaints get spun way out of where they should be, like the chronic pain that occurs after, let's say, you got a surgery or an injury or something like that, and then now you end up having a long-term pain problem that evolves out of that. And a lot of this is because the system, that whole alarm system, is out of calibration or is not working. Sometimes that system doesn't work when it should. The reverse can also be true. So a lot of times you'll have an instance where that system's, again, not working the way it should because it's getting, the signals are not getting processed the way they can. And what we're going to find as we look into some of the neuroscience aspects here in just a little bit too is there's a lot of things that can tweak or adjust how well that system works and whether or not it works the way it should. And some of those things are under our control and some of them are not under our control very well. And there's a lot of different ways that we can intervene as practitioners, as clinicians, to work with people and try to address this alarm system and get it working. Now, pain experiences can be very different from person to person. Even, you take two identical twins who have the same exact genetic structure, same physiology for the most part, they can have very different pain experiences. And a lot of times, sort of in the old days, we referred to this as a person's pain tolerance. And that may or may not be a part of what really is going on here, because what we really learn is that pain is way more complex than we originally thought it was, and it often involves experiences that you've had personally. So for example, you take these two gentlemen here who may be identical twins, but they had two very different experiences because something happened to one of them that was some type of traumatizing event in their childhood. That can play a big role in whether or not they would have pain from the same exact physical stimulus that might happen to them at a later point. So we need to remember that pain is this whole complex web of things that are woven together that may get you into a place of where you would feel that one thing with another. So we're going to delve into some neuroscience now. And a lot of people probably like, oh my God, I thought I left this stuff back in school of having to think about science stuff. But here's the thing. This stuff is fascinating. If you really explore and think about what is going on from the brain and the whole nervous system and how this plays out in the body, this is a fascinating aspect of looking at what happens in a lot of different pain processes. So we're going to take some time to delve into this stuff. And again, if you got questions about this, feel free to ask those, because the more you can kind of get a good solid grasp of what's happening on the neurophysiological level, then you can understand a lot of the other relationships of things that are happening throughout the body. Okay? So let's take a look here. The first thing that we want to start off with in our exploration of this, I wrote a blog post about this a couple, I don't know, year or so ago, something like that. It was really helpful to, when I was learning a lot of this stuff, to recognize here's a challenge that we have when we deal with pain problems, is that a lot of us are finding we have to unlearn a lot of things that we were taught initially. And that's the process of educational evolution always, is that things change, we learn new things. Research comes out that makes us say, hey, wait, what we thought was really happening is not what really is happening. And so this is one of those good examples of how we need to learn how to unlearn some things that we initially were taught. I would imagine most of you, let me just take a quick survey here of the group just to get a sense of who's here. How many of you have been in the massage profession for 2 years or less? Raise your hand. Okay, 2 to 5. All right, 5 to 10. Okay, 10 to 15. 15 to 20. Nice. 20 to 60, let's say. Look at that. Hey, let's give a round of applause to the 20 to 60 group there. Didn't really get to see those data points spread out, but that was a pretty nice curve of experience through this group of people here. So those of you, especially in the 20 to 60 ballpark, you're going to probably have more unlearning to do than some of the other folks will. Okay, but most of us were taught basic concepts or ideas about we have pain receptors in our body, so that when I go over here and I bang my hand on this table, ow, pain shoots up my arm to my head, and that's where it's sort of recognized. But I have these receptors that picked up the signal and sent the pain sensation all the way to my head. That's not really what's happening, okay? Even though that's for the most part pretty accurate, it's not exactly what's happening. Because what is really going on is we have these receptors in the periphery called nociceptors. And they were also frequently referred to as free nerve endings. You may remember hearing about them. The nociceptors are the main sensory receptors in the periphery of our body that pick up signals that are sent to the brain, which eventually become the pain signals that we interpret. So nociceptors are primarily responsive to 3 different types of noxious stimulus: thermal, hot, cold, so excessive heat, excessive cold. Both of those things can eventually produce pain sensations. Mechanical stimuli, like me banging my hand on the table here, a sudden compressive load impacting tissues, sudden tensile loads impacting tissues, those mechanical stimuli that irritate tissues, or chemical stimuli like excessive inflammation after an injury condition also produces sort of a chemical soup around the injury site, which has all sorts of inflammatory chemicals around there. They may irritate the nociceptors and produce pain sensations in there. So these are things that are going to eventually lead to sensations that will come to the brain, and it is at that point essentially that the pain sensation is produced. So it's not produced here at the periphery. It really happens once it gets to the brain. So this is what a big piece of information that I want you to come away with from this weekend as we talk about this is essentially pain doesn't occur until the brain says it does. So when we go to use that alarm analogy, for example, think about the alarm system. There's a sensor in that alarm. I just had a smoke detector issue in my house. I have this one smoke detector that's in my kitchen, and it takes just the most minuscule amount of me overheating some olive oil to set that smoke detector off, and so I was attempting to fix it with a baseball bat, okay, because that seemed to be the most appropriate answer to the problem, okay, because I'm really tired of that thing going off. And so I unhooked it and, took the wires off and pulled it off the wall. And I don't know, somebody who knows something about insurance may be able to tell me this truth. My wife was telling me, you can't do that because if our house burns down and the fire department determines that you unhooked your smoke detector, the insurance company can refuse to pay for it. So I'm going to have to fake rewire it somehow. With a baseball bat, yeah. So that sensor that's in the smoke detector is highly tuned. I don't want it to be so highly tuned, but it goes into a central processing unit inside the smoke detector, and that's where the alarm system happens. Okay, the sensor's not making the alarm, but it's the sensation or the signal from the sensor that goes into the central processing unit of that alarm system that makes the alarm go off. That's essentially what's happening with us, which is that we get nociception, which is the sort of process of that signal transmission from the periphery, but it happens, the pain sensation gets generated or occurs in the brain. And so frequently, if you read any of the pain science literature, you'll frequently hear this phrase or see people talking about or saying, pain is an output of the brain. And that's what we're essentially meaning, that the pain sensation occurs in the brain. Now, this is something I want to make a big point about right here because it is one of the most challenging facets of the applications of pain science because it is one of the most abused and misunderstood concepts. Because what often happens when you start trying to explain this to somebody about pain being an output of the brain, there's oftentimes an immediate jump into that very distorted concept of oh, you're telling me this is all in my head, okay? And unfortunately, many patients have been told this by health professionals at one time or another in their past, oh, this is all in your head. Back in the old days, decades ago, this was sort of glommed into something called a psychosomatic complaint, meaning this is something that you're making up, or really this is a psychological problem you have, that your pain sensation, because we can't find anything wrong with you, it must be something that you're making up. And I don't know if you've read any of the gender studies on pain complaints, but this actually was done far more frequently to female patients than to male patients. And there tends to continue to be, I think, a very strong gender bias about the way this is done. Actually, too, interestingly, I was reading a study the other day that was talking about nociception and the pain processes, and they were doing some evaluations of the amount of nociceptive activity that was present, and there actually is a gender difference. There is a far greater degree of nociceptive activity present in females than in males, and that's one of the reasons that women, well, that we speculate at least anyway, that women oftentimes have greater degrees of pain and more pain complaints than a lot of the men have. And since the male species tends to dominate the healthcare system in many instances, that gets sort of misappropriately identified. Yeah?
Well, I wonder if that's true about boys and girls. I wonder if that has something to do with having been pregnant or something.
Yeah, who knows? The question about does that have to do with, having, you mean like having children, would that have something to do with that, or, yeah?
Well, like I said, I wonder if boys and girls are also different in how they...
At the young age, yeah. And I don't know. I don't know the answer to that. Yeah, it could be. Some things to explore. I think it's a great idea to do, physiological testing on those little rogue rats. Take them in the laboratory and figure out what that stuff is going on with them. Yeah. So we'll have to do that, explore it, and see what happens. Yeah.
Apparently, there's a study that was done, and they were saying, I don't know if it's true, that redheads are more susceptible to pain.
Really?
Yeah.
Interesting. Now, did everybody hear that? She said there was a study that was saying that redheads. Now, do you know if that was just redheads or if that was also fair-skinned redhead? Yeah. So that we're more susceptible to pain? Yeah. So we do see quite a number of different physiological variances between ethnic cultures. There's, if you read any of the studies about various different physical disorders, like certain types of things occur far more frequently in these different genetic populations.
Skin cancer.
I don't know why. Yeah. So, well, obviously, and skin cancer is a great example of that, too. Some of these things do happen to occur more frequently in different genetic populations. So the whole thing about nociceptive sensitivity, that's an interesting thing. So we have to delve into why does the Scandinavian Irish culture feel pain more? Okay, it's because of the whiskey. Okay? Now wait a minute, that should be backwards. They should be not. That's why there's so much whiskey drinking. Okay. Correlation. Okay. Now, when you start looking at science, there's this great website, and I can't remember what it was. This is a thing that lots of people, and this is a good warning thing to look up. You have to be careful when you look at factors that coexist, because correlation does not equal causation. And a great example of what that means is like just because something is there, two things are there together doesn't mean one of them has caused the other or that they're even related. And the way they did this was they put two graphs overlying each other for all of these different factors. For something like the number of people born in the first 2 weeks of September got like a direct overlay on the map of the number of people who are killed by donkeys or something like that. Okay? And they did all these comparisons of these things that were just like exactly the same on the graph, but you can't say that just because those things are the same or they are correlated, there's no causation. At least we don't know what the causation is between early September births and donkey deaths. Okay? Maybe there is one. Okay? But hopefully we'll explore that a little bit later. So this is a big factor. When we get talking a little bit later on, and Nora's going to talk about this some too this morning, about talking to people about pain. That is a big factor we're finding now in helping many people with certain types of pain complaints, is to help them learn how pain really works in the body. And this is one of the biggest challenges in that process, is to do it effectively so that you don't bungle the message and get somebody walking away with this idea that, oh, you're telling me this is all in my head. And I will tell you, having bungled that message with people before, attempting to do that, that it's easy to mess it up. So it really takes some skill and ability to do that effectively and in a way that it gets a good cohesive message across. Because remember, people, sometimes they don't hear the whole story of what you're saying. They may only hear pieces of it and then pick that up. Okay, yeah?
Do traumatic brain injuries disrupt, affect, change people's pain perception?
I don't know the answer to that, but I would suppose that there is a significant degree of impact from different types of traumatic brain injuries, but I don't know a lot about TBIs in relation to pain perception. Anybody else know anything about that? Or
Normal research was like concussions with football players.
Uh-huh.
They're finding their sensitivity and emotional states as well as just being less. That's why you're finding all the suicides and murders from the severe head traumas.
Right.
Back to back to back to back.
Yeah.
And then keep playing back to back to back.
Yeah, so we was talking about the football players, and a lot of those studies were showing some of those kinds of increased degrees of sensitivity. I think as we continue to study that process more, we'll be seeing a lot more of those kinds of things and have a better idea of how they're playing into that. Yeah.
Decreased in the availability, but what they're finding now too, I don't know if you just read the article that came out probably last week about craniosacral therapies, helping to diffuse a lot of those sensitivities.
I saw that, yeah.
Speaking from experience, I've had 9 concussions, and
Yeah.
in that way too, it's definitely helped a lot.
Yeah, so, and this is a great example of why. Yeah, can you just, yeah.
I'm sorry. So with what part, everything? Or
Just the last part of what you were saying about the
So there's an article that came out, I believe last week, about how craniosacral therapy is helping people with concussions readapt their emotional state and also certain sensitivities to certain things. Speaking from personal experience, I've had 9 concussions myself, and craniosacral and other therapies, energetic or whatnot, have helped me and also friends of mine in the same fields of extreme sports. So it's counteracting lifelong effects, but
Yeah.
it's still in a process.
Yeah. So speaking about something like craniosacral therapy or various other therapeutic approaches, having some benefit with addressing some of those kinds of neural sensitivities that happen. Now, one of the things that happens out of this process, and this is something that causes a great deal of tumult within all of the communities of clinicians and healthcare professionals, is that as we learn more about pain and how pain works and how it's sort of changing our understanding of physiology of what really happens in the body, it's also causing us to turn that same lens of inquiry and investigation into what we do to treat pain. And as a result of that, it's allowing us, well, I say allowing us, some people think that it's more forcing us to question and investigate what we're really doing when we do things to people. Because what we're finding out now too is that one of the byproducts of this whole pain science growth, if you want to call it that, this whole pain science world, is that it's causing us to re-examine the physiology of what happens during clinical interventions, be it PT, be it chiropractic, be it massage therapy, osteopathy, whatever it is you're doing. And we're really saying, hey, you know what? We've always known that this works. Just use craniosacral as an example. We've always known that this thing works for these types of things, but what we're really finding out now is it doesn't necessarily work the way we thought it did. And that's actually really important. My friend Todd Hargrove, you're going to hear from later on this morning, Todd wrote that blog post that you wrote about why something works. Was that last year that you? Yeah. Great blog post on Todd's site about why it's important that we understand why a treatment works. Take a look at that and read that. Todd, what is your site that people can go to read that? Bettermovement.org. Bettermovement.org. And he's got it.
I think the post is called 3 Reasons It Matters Why a Treatment Works.
Yeah. Read that. It's really informative and gives you a good sense of the importance of why we have to look at those things and how it helps us clinically to think about and really consider the physiology of what's going on there. So bettermovement.org and read all the other blogs that are on there too, because he's got a bunch of great stuff on there. Okay, yeah.
Some people think that pain is an emotion. And some people think that everything starts in the brain. So here we're like, it's not in your head, but it's in your head. So where do you go with that?
So yeah, so the question, like if some people are saying, you know, that pain is an emotion or pain is a response, or, you know, it's happening from the brain, but it's happening from other things as well. So what we're going to see, and this is where we're going with this eventually too, is that pain just is a lot more complex than we thought it was. And it actually is all of those things. It's psychology, it's biology, it's your social environment. It is all of those factors wrapped up in a, what was that movie? JFK. The movie JFK, it was an Oliver Stone movie. Y'all see it many years ago. There was a great scene in there where Joe Pesci is, he's playing, what was his role in that movie? He was, anyway, they were investigating the assassination of JFK. And he was talking about that whole thing, and he said it's a mystery wrapped up in an enigma, wrapped up in a, you know, something or other. Anyway, the whole thing spun out of like, we just sometimes can't know all of the different facets and how they contribute to what's going on. And that's one of the things that we're finding about this whole process, is that oftentimes it's way more complicated than we thought, and it involves lots of different stuff, some of which we can never know about. And we can't know about in strong enough depth and background sometimes to really make a good intervention with. So we have to do the very best that we can to get in where we can get in and recognize our benefits and our limitations in being able to get there. Okay? So now I want to look at a couple other neurological concepts here about the way pain is processed through the body and goes to the brain here. One of the helpful distinctions that we can make as we're trying to explore pain, and especially explore musculoskeletal pain, which is where most of us live as massage therapists trying to deal with people having various pain complaints, is there's a distinction made oftentimes between what's referred to as nociceptive pain versus neuropathic pain. So nociceptive pain is primarily going to be that which is stimulated, perpetuated, and sort of generated by nociception from peripheral stimulation. Again, this could be the mechanical, thermal, or chemical stimuli of those nociceptors, but something is stimulating them and causing those sensations to go to the brain. Neuropathic pain refers to pain that is generated from inside the nervous system itself. This could be things such as, it could involve the peripheral nervous system, where you've got sensitization of nerves themselves, like in diabetes you have a lot of nerve pain, for example. Other types of musculoskeletal disorders may also involve pain generated from within the nervous system. Sometimes you get a nervous system that's just so out of whack that it causes something called allodynia, which is the sensation of pain produced from something that should not cause pain at all. Have any of you ever had a client that said something hurt so bad that you just drag a finger across their skin and they're like, oh, that hurts? Okay? That should not hurt. That level of pressure on the skin should not hurt. That is a miscalibration of the nervous system that's doing that. That's a neuropathic type of pain complaint. So recognizing the difference between these helps us determine how we're going to approach this from a treatment perspective. Are we going to try to do something with local tissues that would be helping decrease this nociceptive input on a local tissue level, or are we going to try to focus our attention on settling down the whole nervous system, because this is primarily a neuropathic type of event? And one of the things that I want to tell you is that this is another reason why I think what massage therapy does is so magnificent and beneficial for treating pain complaints, because we spend far more time with people in the treatment room than almost any other healthcare profession, and we do so in a way that heightens the benefits of a lot of different aspects of pain management. The soft lighting, the quiet sounds, the scents, the smell, the caring, compassionate touch, which goes back to hardwiring of our brain from little children, the stroking and soothing activity of our parents as they stroked us when we were babies. This is hardwired into our neurological system, that this helps settle us down and relieve our discomfort. And what do we do all day with people? Soothe and stroke them, okay? It has huge therapeutic benefits in what we're doing in the treatment process. So this is one of the things that we really want to take advantage of with our massage applications, and finding out, you know, how we can most beneficially help people get to that point. So making that distinction helps us make some determination about where we're going with our treatment approaches as well, okay? Now, this is an interesting little thing that I want to get you thinking about here. If you have, and this is kind of going back to our original ideas, what made us start re-examining pain problems. If you have an injury condition that produces pain in your body, we should have a pretty straight correlation between pain and tissue damage, so that the greater your pain is, the greater is the level of tissue damage, and vice versa. And that, if you plot that on a graph, would look pretty much like this. Is everybody clear with that? But what we really have frequently, let me see if I can do this here a second, is something that will look more like this. This is my attempt to draw kind of a straight line. Can you see that yellow line there? Okay. Sort of. Something that looks like that. Somebody who has an exaggerated degree of pain, heightened degree of pain, but very little tissue damage. Okay? These are oftentimes your chronic pain patients, the people who get thrown out of the medical system because we can't find anything wrong with you. We've taken x-rays, we've done MRIs, we've done CAT scans, we've done blood work. There's nothing wrong with you. Oftentimes these are it's all in your head, this is a psychosomatic issue, you shouldn't have pain, go see a psychologist, okay? They fall through the cracks in our healthcare system oftentimes because there's problems in the fact that our medical system is very much based on a mechanical or mechanistic and Newtonian model of how the body works, and when we can't find an explanation for that, it doesn't make any sense. But is it real? Ask somebody who's living through that. Anybody in here have chronic pain or had that kind of experience? Is it real? You bet your ass it's real, okay? It hurts, it affects their life, it affects their social relationships, everything like that, and it is something that is difficult to find a command or way to address. Correspondingly, we have these other things now that we also recognize can happen, which also seem pretty darn bizarre, which is this, okay? Person with extreme tissue damage and no pain, or little amounts of pain. And we see a lot of these stories come up, especially in environments where there is a heightened degree of some other type of distraction. For example, a lot of these stories come out of the military in warfare and in high intensity, high stakes athletic events, the Olympics, you know, the national basketball championships or whatever. Somebody's jumping, they land, they sprain their ankle, and they keep playing. And after the game is over, you know, their knee is swollen and they're in tremendous pain, but they didn't feel anything during the game. Why not? There was tissue damage there, right? Why does somebody get shot on the battlefield and they don't feel pain until they go to the medevac tent hours later? Because pain is far more complex than just the tissue damage. Remember, the nociception went to the brain, but the brain has the capability to say, actually, you know what? There's something more important happening right now about get your ass off the battlefield so you can survive. That's more important than worrying about the fact that you got shot in the shoulder. We'll deal with that later on. And later, you will often have significant pain that will happen as a result of that process. So when we see and start really thinking about this and evaluating it, if that really is true, that you can have this exaggerated degree of tissue damage and no pain, then pain can't be coming exclusively from the periphery of those damaged tissues. It has to be getting generated in the brain and being modulated, either ramped up or ramped down by something that the brain is controlling. And that's really the crux of this thing that's helped us kind of get to understanding that the pain sensations really have a lot more to do with neural processing here in the brain. Yeah?
More of a comment, but just I see that the most in car accident situations where it takes a long time for them to manifest any kind of symptoms
Yeah.
after having, not even maybe a particularly bad accident.
Yeah, so just talking about car accidents, how we see that kind of thing. You see this a lot, especially in whiplash injuries, the delayed onset of symptoms that happen sometime later. And the insurance companies hate this because it's really difficult to, they want to be able to tie these two things together. Well, you didn't have, this was a pre-existing problem, we don't have to pay for it, or you're creating these symptoms after it was over because they didn't happen right after the injury, so we don't have to pay for it. This really creates a messy situation in the reimbursement world. But the problem is the reimbursement world is going to have to come to grips with medical reality at some point and figure out how to deal with this, because the more we're learning about these things, we're learning you can have an injury that does not really show up with significant pain problems, complaints until much later because of the way that sensitization of the nervous system happens, and it started from that accident. Okay, yeah, Leslie.
So this is why then compensation and patterns over time, that they aren't seeing it for the 20 years. That's why you always say, well, you've been compensating in patterns over time, but it's because this guy here said, oh, it's more important for you to work, kill the woolly mammoth, bring to the people the food. Yeah. And then 20 years later, and then your medical professional is saying, oh, it's old age. Yeah. Right. Is this part of that, why the compensations and patterns over time don't show up right away? Yeah, well, it's part of that. So the question was about compensation patterns and things, why they may not show up right away. But a lot of this, some of it also has to do with both age and load and time, for example, which is that at a certain point when you're young and resilient, your body can handle a lot of different types of things and not be having necessarily problems from it. And as we age, some of those things just get more cranky and tend to last for a longer period of time. And they don't tend to follow the rules the same way, and they can have greater degree of sensitivity with that. Well, isn't it also cultural because we take for granted, the body, says, oh, you're going to die at 40. But now we live to 100. Yeah. And so, but we still treat, because we don't feel pain right away, we treat our bodies like we die at 40, even though we don't. And that if we would younger start treating and being strong and knowing we need to be strong for this life, and just because you don't feel it doesn't mean that there's nothing wrong. Absence of pain is not wellness. Right. And the same thing is true, like what you were mentioning too here about, cultural expectations and the way we process those kinds of things play a big part in this as well. My friend Doug Nelson, who's the president of the Massage Therapy Foundation, wrote a really good book on pain that's a very easy introduction to some of these concepts. I would really encourage you to take a look at it. It's called The Mystery of Pain. And Doug has a anecdote that he tells in this book. It's a great illustration of this whole idea of societal factors. He is of Norwegian descent, and he said there is a saying in his culture amongst the Norwegians that somebody who talks about something that hurt, he said, yeah, it hurt so bad I almost said something about it. So in that culture, you don't talk about pain, you just sort of take it and deal with it. And that, for many people, makes them feel it less, because that's just well, oh, this is something that we just sort of deal with these kinds of things. Culturally, this can play a role in whether or not you would actually really feel it the same way. So those things, and we see too, again, that they play a role in our capability of perceiving and experiencing that. Yeah?
What was his last name?
Nelson, Doug Nelson. And the book is called The Mystery of Pain. Okay, yeah?
I was just going to kind of ask about the self-perpetuating. Yes, there's pain there, but then telling a story about pain over and over and over and reinforcing the pain over and over and amplifying it and building the neural pathways for it.
Yeah. that is a great example of how this gets perpetuated. She was talking about the sensation of, or the process of reinforcing this over and over again. It's oftentimes referred to as potentiation, which is, it's just like when you see a field of grass out there and you want to get to the trees on the other side of that field, you walk through the path of grasses. The person who comes behind you, are they going to walk their own path through that grass, or are they going to follow that sort of partially trampled path? They will probably follow that partially trampled path, and your neurological system does the same thing. The more you practice or reinforce a motor pattern, the more it gets exaggerated and perpetuated, and that oftentimes leads to a greater increase in those pain sensations being present. Yeah?
Does that also correlate with pain addiction, as far as with, you get pills prescribed, you take all pills, you get addicted because there's overprescribing, but that pain is still there because mentally you still think you have it? Or?
Yeah, so the question about, is that also the same process with addiction, with taking pills? I don't know if that's, psychologically the same process. I would be willing to bet that there is some degree of similarity in that process. I don't know for sure if that's the same physiological, mechanical thing that's happening there. Okay. Yeah?
A long time ago, I studied with a man named Jack Schwartz, who did amazing things with his body, including putting a sailmaker's needle through his bicep, pulling it out, and registering no pain.
Yeah.
He said, of course I feel pain, I just know what's going on.
Yeah.
He understood what was going on, and he could manage his physiological responses around that.
Yeah. So he's giving an example of someone who could put a pin or a nail through his biceps and said, yes, he felt pain, but he knew what was going on, so therefore it was not a debilitating degree of pain. You see this a lot in some of the Asian cultures. They do these things, these major needle body piercing things for ritualistic religious things. There's a huge psychosocial overlay over that whole process that can make you not have a sensation of feeling the actual pain when you're telling your body not to have those kinds of sensations. And knowing something is knowing what you're doing. It would be great if this was really under full conscious control and you could say like, yeah, I know that's not so bad, so I'm not going to hurt from that. But we can't often tell. Some people have a lot more capability to be able to control or work with that part of their brain than others do to be able to do that, because there is something referred to as catastrophizing, which a lot of people will tend to do with certain pain complaints, and you've maybe encountered this with some clients where they have something like, somebody's told them they have a disc herniation. It's like, oh my God, I'm going to die. The world is over. I won't be able to walk anymore. Like that whole process of building up and building up and building up the anxiety, the angst, and the worry, and the difficulty of addressing those things, that all plays into that whole process, what makes the pain worse for them. So, and this is highly variable from person to person about whether or not they will do that. Okay? Yeah?
So is it the psychological or the neuropathic ways? So when a child is born, and I notice it with working with pediatrics, parents, their child is crying and the parent will say, you're okay, you're okay. And so I work to explain that they're obviously not okay. And I wonder, when we were growing up, and especially when I was a child, boys were told, you're fine, suck it up, get up and go. And so they then will work through injuries, and even some of the kids I have, especially boys, even though they've had 2 knee surgeries, will still go out for tryouts and still do things. Won't feel the pain during the time. I'll explain it, but then later there's more of an injury. But they think in their brain that since they were able to do the activity, that it's okay.
Yeah. Yeah, so referring to pediatrics and children and the way in which children feel this, again, I think there's a very strong psychological component to this, and we know this is true about pain in terms of whether or not it's felt knowing, should I be feeling pain for this? And you see this a lot in the discussions of how to deal with kids when they fall and injure themselves and do this kind of thing like, oh no, Johnny, I'm so sorry you fell. Let's pick you up, grab you, hold you like, and you're showing worry, concern, stress, and unease. And Johnny goes like, this is terrible. Whereas the other child sometimes, and again, this is not going to happen all the time, but when sometimes the child falls, you're like, oh, hey, no worry, let's go, no biggie. The child recognizes like, oh, I don't have to be that concerned about that, and doesn't, freak out. My brother-in-law, he cracks me up. He's really, he's a high school teacher, so he knows, you know, all the games that the high school kids play. But when he had kids, every time my little nephew, who's now 6'2", okay, 18 years old, but when he was a little kid, every time he'd fall down, Brady would go, "Safe!" You know, just like he was playing baseball and making a game out of it, just like he was diving into third base or something like that. And it became sort of a game thing. And I watched that process for that same reason and thinking about this. You didn't see Taylor freaking out about falling on his knees and falling down anywhere near as often as you often would. And I think the messages we convey to them oftentimes do have a certain implication of how they're perceived and played out for them, pain-wise.
What's the other side of that? Because what I'm talking about is when the parents and the coaches say you're fine,
Yeah.
this child is not fine. He's limping, he's swollen, but we push them to go through.
Yeah.
So is it psychologically, but they're really actually still feeling things?
Yeah, I think at this point, too, you're talking about a cognitive dissonance about, like, they're telling me not to feel pain, so I'm suppressing those things because my knee really hurts, you know, but I'm supposed to suck it up and be tough or whatever. And that causes, I think, a whole different array of potential problems of
Like
chronic pain or things like that are not being expressed and dealt with appropriately. Okay. Yeah.
So just to go off of what she said, emotional disassociation, and then go back off to what he said, addiction, a form of disassociation. So we're kind of being almost wired to disassociate from our pain, and we're in the fast-paced society, so kind of tying in that social, the norms and the mores that we have kind of going on in culture today.
Yeah.
Go, 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 go hard, even with fitness. You see it all over the place that that's the acceptable, so the increased alarm, stress response, and then disassociating from it, and then increased pain, obviously.
Yeah. So, and we see this as a wealth of really complex factors all wrapped up together. And often, in many instances, it's not one single clinical approach that's going to be the right thing that's going to get it addressed. It's going to be what you do with the person in your treatment room, what they do when they leave. Remember, there are 168 hours in a week, okay? You might see them for one of those hours, okay? The idea that what we do in that 168th of the week is the magical thing that makes everything better, stretching that a little bit, okay? Not to like discount the value of what you're doing, but remember a lot of what happens with a person getting better is what they do with what you give them in that hour outside of that time frame also to produce results later on. Yeah?
I go to a naturopath who never tells you you have a disease. If we have a little imbalance here, we'll take care of it. But yet my clients come in, and if they've had problems through the years, they may have a list of diseases that the doctors gave them.
Yeah.
So they come in to all these diseases.
Yeah.
And I like the fact that we have a little imbalance.
Yeah. So we have this tendency a lot of times to pathologize things that are not so much problems. And we're going to talk about this a little bit later, you know, because this has been the sort of detriment of some of the mechanistic viewpoints in musculoskeletal medicine is we've turned a lot of things into a pathology. Oh man, look at your shoulders. Oh, that's terrible. We're going to have to do something about that, okay? Look at your fill in the blank. Low back, your foot, your whatever. We have to do something about that and fix it, okay? And we have a tendency to turn a lot of these things into pathologized problems when it's just like, you know what? Have you ever seen any of those psychology experiments where they take a mirror and they like put it right down your face in this half of your body here, and then you look at the mirror, it doesn't look like you. Why not? Because we are asymmetrical. Okay, we aren't the same exact from side to side. So you have this, big deal. Okay? Unless it really is causing you a problem, maybe you just have one shoulder that's slightly higher than the other and you're going to be okay. Okay, in many instances. So we don't have to fix everything that looks like it's altering or deviating from the perfect. Okay? What a segue into exactly what we are talking about here. Structure, this is another thing that we've begun to focus on with our pain processes. Structure is not necessarily destiny. Okay? The person who comes in with the x-rays and the MRI, I've got a disc herniation. I have a subluxation. I have a whatever it is that goes on. This is a big problem, okay? One of the fascinating things about the advent of high technology medicine that causes both problems and also sheds light on the fact that these things are really problematic as a test is that we are able to see a lot of stuff that goes on inside the body that we weren't able to see before. Now, your shoulder hurts. You go to see the doctor. They do an x-ray. They say, oh, you got some significant tearing in your rotator cuff processes or your rotator cuff structures. We need to do some surgery. They go in and do the surgical procedure to attempt to fix that. Some people get better. Some people don't get better. Do they do an x-ray or an investigation after it's over to look at it? In many instances, they don't. But you know what would have been really interesting to do, and now we're actually doing this for research purposes and finding out some really interesting stuff. You know what? A whole bunch of the people in this room walking around right now have dysfunctional things on your MRI that would be surgical candidates. Okay? Just to give you a couple of quick stats about this. This was from a couple of different studies that looked at this. 96% of the athletes younger than 22 years old will show changes on an MRI that would be described as abnormal. Okay? Meaning possible candidates for some type of intervention. Okay? 30% of 20-year-olds with no pain have disc degeneration in their spine. 37% of 20-year-olds. They've also done that same study going up the age groups. When you go to 40, 50, and 60 years old, they get somewhere up around 75 to 80% of the population that have no pain have significant disc degeneration in their spine. Degenerative, what's called degenerative disc disease. It's also called aging. Okay? We wear out as we get older. People get rotator cuff tears and go on just fine, never having any symptoms with it at all, because you have other structures that can compensate for this. So the problem often is imaging. This is another one here. 57% of 20 to 50-year-olds with no hip pain have cartilage and ligament tears in their hips. So when you go and you say, like, I got to have a hip replacement because they did an MRI, I'm like, I got cartilage tears. I got cartilage tears. That's serious. Okay, it might be, but it might not be also. And this is where a skillful clinician has to come in and say, when does that matter? And that's the trick, is really answering the question, when does it matter? And that's why reliance on high-tech diagnostic procedures alone and not being a good skilled clinician that does a comprehensive evaluation process, I think, is really acting inappropriately, because you're putting too much reliance on the technological image of what's seen in the body and not saying, hey, does this actually matter in this particular instance? Okay? Because sometimes structure matters. Sometimes the structure is one in which the activities that you're doing are going to magnify your problem and your dysfunction, and it matters. So how do you know when it matters? That's what a good clinician is about. You make some determinations based on signs, symptoms, activities, what they're doing in their life, how that is going to play a part in those various different things. Okay? Yes?
So we're talking about no psi or no C. We're not talking about the neuro pain now.
We're talking about nociceptive pain at this stage here. But you're going to have neuropathic pain that, again, gets started by something, let's say a structural problem or a nociceptive problem, and then it just perpetuates, it spins out of control, and it gets perpetual. Let me give you a good example of that. I like to experiment on myself sometimes to learn things about the body. Serious head trauma, I like to avoid that kind of investigation. But when I can. I had a great example of this with a hand injury that I sustained about a year ago. I was bicycling with my dog, and he jerked over to the side chasing a squirrel, and I fell and sprained my MCP joint on my finger right here, okay? So the finger was thrust in this direction like that. Sudden painful problem, like I knew, like, oh man, this, yeah, I did it there. Easy orthopedic evaluation, you know, pain associated with the movements that stress those ligaments. I thought, okay, no big deal. I'll be over this in a couple of weeks. Life moves on, okay? A couple of weeks go by, still hurts. I said, oh, that still hurts. The friction, I do all the things that I'm supposed to be doing with it. Really weird. A couple of months go by. This thing still hurts. Why does this thing still hurt? And then I'm noticing, I'm starting to panic, okay? Starting to, not panic. Not like the panic button guy there, but starting to think, you know. I look at my hands, okay? You can't really see this very well, but I got a knot, a bump right there, okay? Was that there before? I don't know. I can't remember. I'm right-handed. I spent a lot of time in my youth in martial arts practices, punching things. I might have, you know, built up some osteoblasts, made that bone a little bit larger, but I can't remember whether it was big or not. But maybe that's part of the problem. Maybe there's some, but it's hard. It's not inflamed, you know. Months go by. This thing's still painful. And I'm noticing too, now that it's painful, every time I go to pick something up and grasp something, I'm going, that's going to hurt. I'm telling my brain, I'm reinforcing the messages, that's a problem, that's going to hurt. And it does, and it continues to be a pain problem. And so I was reading a bunch of this pain science stuff, and I was reading about something called graded motor imagery. And I was reading some studies when they were doing what's called mirror therapy for people with various types of arthritic pain, where they get a good hand that is not painful, and you put like a mirror right in between him, and you put your other hand behind there, or you do some things with this mirror, and you move or you manipulate the good hand, and your brain. Here, let me borrow. Can I borrow your little thing for a second? So hold this like that. Okay, here's the mirror. All right. So I've got my hand like this. I can't see this hand. When I look in the mirror, though, what I see is this hand. Okay. And so what I'm doing is telling my brain, all right, watch this. And I move this hand, and then I think about moving this hand in the exact same motions, move my hand all around, all the different movements that hurt. It doesn't hurt because I'm not moving this one. But my brain sees my right hand move pain-free. Okay? And I did this for about 3 weeks, and it's gone. And it was because, you know, I did all of the things that I know to do about orthopedic evaluation that say, like, there's tissue damage, there's nociceptive problems in here, and none of it did anything. And this pain had gone on for so long that it was pretty clear this had become a neuropathic process that was a pain thing that was getting perpetuated by sensitization for whatever reason. I don't know why. I can make up some psychosocial reason that I have, you know, hand pain or whatever. I don't know what that it was about. But what I do know is something was happening in my brain that was making it perpetuate. But I found an intervention to basically trick my brain into saying, there's no reason for you to still have pain here. This can be a free, easy movement. Now, I still got the bump. I think it was probably there before. I think it was irrelevant. Okay. The tissue doesn't hurt any longer. I can, you know, press on it, move it, all of these things around there. I don't think it was anything that was healing the tissue per se that did that. I think it was about neuropathic processes in the brain that were getting us there. So that's an example of using evaluation and clinical reasoning processes to think, when is this becoming a neuropathic process that can be addressed one way because all the massage and soft tissue work and everything else didn't really do much. It really got done or addressed through other kinds of approaches. Yeah?
I had a patient who was a military man that lost his leg. Came in one time and I had read an article about massaging the phantom leg and it would take care of it. And I did, and it did happen.
Yeah.
Is that the same concept?
Same concept. When we talk about phantom limb pain and the fact that we can sometimes treat or address those because, and we're going to talk about this a little bit later too, that the brain has a map of the body in there. And that's why you can still have pain in a non-existent limb, is because that map is still present and is still working. And we have some ways to kind of work with that and do those kinds of things.
When I massaged that I just followed his other leg and pretend I massaged it, and his pain went away.
Yeah.
And he was surprised.
It's fascinating, isn't it? Yeah. It's fascinating to be able to trick the brain those ways and make it. Now, placebo. Lots of people have heard the term placebo. Has anybody heard the term nocebo? Okay. May not have heard that term. Be careful about nocebo and nociceptive processes because you can make pain worse with them. A nocebo is something where it's the opposite of a placebo. You make something worse by thinking about it or doing something to it. Okay, I put this, oh, you can't see that quote very well up there because it's white. Should have done that in black. But how many times have you heard people say, you know, you start working with somebody, oh man, your traps are awful. They're really tight. This is the worst traps I've ever found. You know, like these things are really, boy, what have you been doing? You know, you are putting messages into their brain and nervous system about how bad they really are, and you're reinforcing that process and making it worse. Now, people will often ask you, are everybody's shoulders this tight? Mine are really tight. Is everybody like this? And you have ways to either reinforce or unreinforce that message with them. So be careful about the way you talk with people because that can really make things worse or better the way that you do that. And that's why languaging is tough. Languaging is a challenge for how do you figure out how to say those things appropriately in the right way with everybody. Okay? Let's go this way. So we talked about this a little bit earlier, but this is the dominant model that has now become present, is the biopsychosocial model. And essentially what this is previously we have spent a lot of the time focusing on this component here, the biological. Okay? What's wrong with the tissues? Why do you hurt? What's damaged? What structure is a problem or whatever? But now we're recognizing that pain is a far more complex process that involves psychological components and social components as well. This thing is all wrapped up together as part of the pain process. And sometimes we will make an intervention here. Sometimes we will make an intervention here in the social world of what's going on at their home environment, of how is the support network and all that kind of stuff. Those are factors that will all play a part in whether or not they're going to experience pain. So we have to keep in mind that what we're doing is a lot more than squeezing and mashing tissue. Okay, there's a lot. And massage therapy is one of the most powerful and ideal biopsychosocial interventions in the healthcare system because of what we do, spending a lot of time with people, directly working with them, caring, compassionate touch, soothing, warm, calming environments. All of those things add up to be a really powerful intervention with people. So take advantage of that to a great extent here. Okay. Greg Lehman, who's a physiotherapist, chiropractor up in Canada, has this great concept. And down at the very bottom here is his website, Greg Lehman, GREGLEHMAN.ca. He's got a workbook that you can download off this website called Recovery Strategies. And in his workbook, he talks about each person comes to us like a cup filled with all of these different factors that may play a part in whether or not they will experience pain. Tissue injury, kinesiophobia, what is that? Fear of movement. I can't move this shoulder, it's going to hurt. Okay? Being careful about that. All those things are potentially problems. Vomit. Anybody know what that is? It's not what you think it is. It's an acronym, okay? And we talked about this earlier. Vomit is a victim of medical imaging technology. Okay? The person who's been shown their x-rays and now has a negative perception about, oh, I'm in a real problem. Okay? I've got this shoulder tear, I've got this hip labrum tear, I've got this disc degeneration, whatever. And now that lays over into what's going on with them. So that can mean, they've done some studies, in fact, it was fascinating. They had a group of people who had reported back pain, and they did MRI studies with them. And then they came back and they had like one MRI study of a really bad back with a really bad degenerated disc. And they showed it to all, the same study, to all these people with back pain. One group they showed it to, one group they didn't show it to. the group that they showed it to, they reported higher pain scale reporting after having seen the MRI of their back, which wasn't their back. Okay? So it definitely indicates that we can be influenced by those things in negative ways in many instances. So look at a person's cup. See what's involved with that cup. How can we intervene on those various different factors? Because it's unique to each one of us. Each one has their own cup and what's in there. Now what we also learn from this is that when we learn about pain, we can help reduce pain. So learning about it can help reduce it if it is done right. And we said earlier, that's the trick, is being able to help learn how to do this correctly. And oftentimes we'll do this in two different ways. One is called a bottom-up approach. This is what we do in the treatment room most of the time. We do some work on peripheral tissues that send signals up to the nervous system, and that's sort of a going upwards approach. A top-down approach would be one in which the person is being given information, told things, taught about pain science processes, therapeutic approaches that work predominantly on what your brain is thinking or doing about. For example, the mirror therapy stuff that I did is a top-down approach, really, because I'm working on the brain. I'm not working on my hand. So those are two different types of strategies or approaches that may be used, both with different benefits to each one of them there. Okay? So think about this. This, again, makes the therapeutic arsenal a little bit bigger for us to address. This is a really good reference point for what can help make things better. This is from a book called Explain Pain by Lorimer Moseley and David Butler. They talk about trying to focus on DIMS and SIMS. DIMS is an acronym for danger in me. These are all the things that may potentially make something worse, make it more aggravated, irritate the pain sensation. And the SIMS are what they call safety in me. Some of those things that make us feel better. Of course, soft tissue work, massage. Massage therapist in Minnesota named Jason Erickson invented this wonderful word, yesiception, okay, which is the opposite of nociception, okay. All of those things that instead of sending signals up that are interpreted as irritants and noxious things, they're interpreted as, hey, that's pretty nice, I like that. Soothing, gentle things, all of those factors can lead to an increase in, or a decrease in pain sensations and increase in the overall optimal function. So we want to try to focus on maximizing those SIMs and minimizing the DIMs whenever possible. Okay? If you got some time and you want to explore this stuff in greater detail, David Butler and Lorimer Moseley are two of the leading pain researchers down in Australia who've just got a wealth of information that they've put together and a great website and some other books. Their website is the Neuro-Orthopedic Institute. Do you know, is it NOI.com? Is that right? Okay. NOI Group, yes. And is it .com, do you know? Yeah. Just put NOI Group in your Googler, and it will, you'll find the Neuro-Orthopedic Group down in Australia. Great resources to look into this a little bit further. Couple other quick things that I want to talk about here regarding some neurophysiological concepts. Ascending facilitation is a process that can happen neurologically that magnifies the sensations that occur. So when we were talking earlier about allodynia and hyperalgesia, that happens because something in the nervous system is turning up the volume on the pain signals. And so we see this occur in something called central sensitization or peripheral sensitization when it's out here at the nervous tissues themselves. We're ramping up the signal through something called ascending modulation. And that means something, whatever it is, various factors in the environment or various things out there have caused that signal to get bumped up in its importance level. This can produce allodynia, which is that painful sensation to something that shouldn't be painful, or hyperalgesia, which is when a pain is just greater than it should normally be. Okay? It hurts a little bit, but if I have hypersensitivity or hyperalgesia, that hurts a lot more than it should. Both of those things are happening oftentimes because of ascending facilitation. Yeah?
Does fibromyalgia play into any of this?
Absolutely. Question, does fibromyalgia play into any of this? And this is absolutely we're in the wheelhouse of fibromyalgia. Lots of issues with allodynia, hyperalgesia. We still don't have a really good grasp on what it actually is, but there's stronger and stronger indications that this involves a lot of central nervous system hypersensitivity and misprocessing things in there for whatever the various different cause and reasons are.
Yeah.
But yeah, it plays a big part in that. And therefore, our interventions for fibromyalgia that involve maximizing those SIMs and minimizing the DIMs are the best way to try to address that with many different people.
In the years that I've been practicing, I've found either people are self-diagnosing, fibromyalgia. It's easy to Google WebMD or whatever.
Yeah.
But also doctors diagnosing them because we don't know what else it is. It's just such a blanket term.
Yeah, absolutely. So those are definitely big factors in a lot of different chronic pain complaints, but they definitely fall into this. Now, you have these two or several different types of main nerve fiber types. Don't worry about this too much at this time, but I want to focus and just call attention to down below here what you may see if you read some more about this. Predominantly your A delta and C fibers are the main ones that are involved with nociception. You have these other different types of fibers like the A alpha and A beta fibers, which are mainly involved with proprioception and mechanoreception in the body, sensitive to pressure, vibration, and movement. You all have probably heard of the gate theory of pain. You heard of that? Okay. This is how this is essentially working, and this is the opposite of ascending inhibition. And what happens in the gate theory is essentially what we call, oh, you know what? Sorry, this should say descending modulation. I did that up there at the top. That should be descending modulation or inhibition. What happens here is the brain is inhibiting or limiting the signals that are getting up. Those A delta and C fibers are the ones that are sending a lot of those nociceptive signals into the central nervous system, but we're doing movement or proprioception or some other thing. Like when you hit yourself and you hurt yourself, you're like, oh man, that hurts. Why do you do that? Okay, because movement and proprioception can override those nociceptive signals from the A delta and C fibers and inhibit through the brain's processes whether or not those signals actually come up and turn into what's perceived as pain. So we actually have a lot of strategies, and massage is one of them, that will focus on maximizing the role of descending inhibition. And this is a big part of what we're doing. So descending inhibition works through that whole process of the brain actually sending a signal down that will inhibit the nociceptive activity from coming back up there. So that's what we want to try to maximize as much as possible. If you're interested in learning a little bit more about this physiologically here, I would really encourage you, a lot of you may not be like real excited about reading research papers, but I'll tell you there's some really, really valuable and good stuff out there. This is a great paper to take a look at. It's called The Role of Descending Modulation in Manual Therapy and Its Analgesic Implications. It explains this whole thing in great detail. All right, a whirlwind of things that we got through here. Pardon me for running 2 minutes over. Okay, we're going to take a little break here, and then we're going to come back and Nora's going to explore some more fascinating aspects of pain management stuff with us. Any announcements that you want to make for us?
We got 15 minutes.
15 minutes, okay, 15 minutes. Questions that didn't get answered, come ask me. I'll be happy to chat some more with you all or explain some other stuff with the things that we did here, okay? All right.